Well, good morning, everyone, and welcome to Cardiology Grand Rounds. My name is Jim Kirkpatrick, and it is my distinct pleasure to introduce our speaker today. Mike Morkos is a bit of a UW lifer. He did his undergraduate training here, graduated magna cum laude, and then stayed on for medical school. He then joined the internal medicine residency program and then spent some time as a cardiology hospitalist. And during this time, I remember it well, he really impressed everyone with his clinical acumen and can-do attitude. He joined our cardiology fellowship in 2018 and has been one of the stalwarts, both in clinical medicine and also in teaching. On the research front, during his time at the University of Washington, Dr. Morkos has been involved in a number of very interesting and important projects. While as a resident, he examined morphologic and functional differences in transposition of the great arteries. And over his time, he has also been involved in a number of very important quality improvement projects that have left their mark and really done great things to help our patients and our systems work a lot better. Over the last several years, he has been working primarily in the area of cardiac imaging, examining such things as echo and cardiac CT outcomes and parameters for atrial appendage occlusion. And he has also been looking at a number of different cardiovascular outcomes that are associated hospitals in COVID-19 quality improvement initiatives. And we have also had the benefit of his working in the area of his topic today, and that is examining mitral regurgitation. And he's currently involved in a project and has helped set up a multi-center project examining echo and patient characteristics of successful Microclip outcomes. I have gotten to know Mike over the years, and I have to say he is one of the most enthusiastic people I have ever met. It is literally a joy and pleasure to interact with him at every point, whether it's in the Echo Lab or on the services or during research projects. And I know that he is going to bring that same level of enthusiasm and excellence to his talk today. Mike, thanks so much for giving this talk, and we look forward to learning from you.
Well, thank you very, very much, Dr. Kirkpatrick, for that very generous and warm introduction. It's my pleasure today to be able to be here and chat with you all about a topic of interest in secondary mitral regurgitation. And in particular, I want to focus on treatment strategies and therapeutic considerations for patients in this arena. I have no pertinent financial disclosures or conflicts of interest to report. And I'd like to start the talk today with two patient examples of real-world patients we see here at our institution. Our first patient's a 65-year-old gentleman with a history of dilated ischemic cardiomyopathy and class 3 heart failure with secondary severe mitral regurgitation. And he's on guideline-directed medical therapy, and he's referred to us for consideration of transcatheter edge-to-edge repair with Microclip. He gets a transthoracic echocardiogram here at our institution, and we'll walk through some of the pictures. We see his peristernal long axis images here of the left ventricle and the mitral valve. And he has a moderately dilated left ventricle with an end diastolic volume of 180 milliliters. He has severe LV systolic dysfunction with an ejection fraction of 25%. And you can see the color Doppler of the mitral regurgitation jet on the right. The mitral regurgitation is ultimately graded as severe, and he has an effective regurgitant orifice area of 0.44 centimeters squared and a regurgitant volume of 52 milliliters. The spectral continuous wave Doppler on the right just demonstrates a very triangular appearance of his MR jet, and it's a very dense waveform consistent with his severe mitral regurgitation. Our second patient, in contrast, is a 63-year-old gentleman with dilated ischemic cardiomyopathy who also has class 3 heart failure and severe secondary mitral regurgitation. He too is referred for consideration of transcatheter edge-to-edge repair. And he also gets a transthoracic echocardiogram here, and he's noted to have a severely dilated left ventricle with an end diastolic volume of 210 milliliters and severely reduced systolic function with an ejection fraction of 28%. His mitral regurgitation is graded to be moderate to severe with an effective regurgitant orifice area of 0.32 centimeters squared and a regurgitant volume of 41 milliliters. Now, I think it's easy to highlight the similarities between these two patients because there are a lot. But I'm going to focus on some of the differences that I think are not only pertinent to their clinical histories, but also a topic of much debate in the space of secondary mitral regurgitation therapy. And many people consider secondary mitral regurgitation as a more homogeneous mixture, when the truth is there's a lot of heterogeneity to these patient populations. And that will be some of what we come back to a little bit later in the talk. For anyone playing along, I don't think it's fair that I gave you enough time to spot the differences between these two pictures, but I could come up with at least 5. If you find more, please let me know. And so with that background in mind, I'm going to spend much of our talk today kind of defining secondary mitral regurgitation and reporting why it's significant in this field, discussing the pharmacologic and non-pharmacologic strategies we have at our disposal to treat these patients, as well as discussing the invasive mitral regurgitation reduction strategies, with a focus at the end on considerations for selection for edge-to-edge repair. And we'll first start talking about just some of the basics of secondary MR and its overall importance. And so, as to no surprise to the people in this audience, mitral regurgitation is generally thought of in 2 classifications. The first being primary mitral regurgitation, where there's an inherent structural abnormality to the mitral valve itself, something like a flail leaflet. And then the focus of this talk is on the secondary mitral regurgitation, or mitral regurgitation that's seen as an effect in an inherently normal mitral valve, but in the setting of either ventricular, atrial, or chordal remodeling secondary to another process. And even within the sphere of secondary mitral regurgitation, there's a variety of different mechanisms that lead to it. In the setting of heart failure, for example, left ventricles have reduced contractility. They become more dilated and spherical. And there's actually a fair amount of dysynchrony, not just between the ventricular walls themselves, but in the papillary muscles. The papillary muscles are frequently apically displaced, and they result in chordal tethering, as well as abnormalities that occur at the level of the leaflets, with posterior leaflet restriction and sometimes anterior leaflet restriction as well. The mitral annulus loses its classic saddle shape pattern and becomes more flat and dilated. And all these kind of work together to create mitral regurgitation. Now, as imagers, it's really important for us not just to report how severe the mitral regurgitation is, but in particular to notify the providers on what the mechanisms behind it are, not just even primary and secondary, but the features of secondary MR that result in the mitral regurgitation. And so the presence of mitral regurgitation is quite important, as it's been shown many times to be a predictor of overall mortality. In this study in 2001 that was published in Circulation, patients who arrived with ischemic cardiomyopathy and those who came with acute coronary syndrome were divided into those who had mitral regurgitation and those who didn't. And there was a clear survival difference in patients with and without mitral regurgitation. And the severity of mitral regurgitation was also able to predict outcomes overall. This study was repeated roughly a decade later and looked at patients not just with ischemic cardiomyopathy, but both with ischemic and non-ischemic cardiomyopathy with a similar story. Now, granted, there's a fair amount of confounding variables that go into this, but when they try to adjust for left ventricular ejection fraction, the hazard ratio of severe MR was still predictive of overall outcomes in this patient population. And it's not just heart failure with reduced ejection fraction either. It's those with preserved EF and heart failure where the severity of mitral regurgitation in secondary MR is also predictive of overall outcomes. And so we know from the data that left ventricular dysfunction leads to morbidity and mortality. I don't think I'm surprising anybody by drawing that relationship. And that left ventricular dysfunction can lead to mitral regurgitation as well. But that the combination of the two incurs a worse morbidity mortality than either one on its own accord. And so hopefully I've had an opportunity to kind of define some of the basics of mitral regurgitation. And now I'm going to be spending time talking about what we consider to be some of the mainstays in heart failure therapy and how that relates to the management of secondary mitral regurgitation. So it's no surprise to people that guideline-directed medical therapy works for the management of LV systolic dysfunction and overall remodeling. And when taking a look at many of our pharmacologic strategies with secondary mitral regurgitation, there's also a noted benefit as well. This paper published in the 90s took a look at the effect of ACE inhibitors, in particular captopril, on patients with left ventricular systolic dysfunction and secondary mitral regurgitation. And what they saw was a benefit in mitral regurgitation, and that was not fully explained by the drop in systemic vascular resistance alone. So it's not just afterload reduction that's working to improve these patients' overall mitral regurgitation, but it's also probably the effect of the ACE inhibitor on the ventricular function as well as the ventricular physiology and anatomy. And this was seen as well with beta blocker therapy in a study published in 2000, where they took patients who had secondary mitral regurgitation and LV systolic dysfunction and treated them with both carvedilol and had a control group with placebo. And so to kind of orient these graphs, baseline mitral regurgitation is here on the x-axis, and the change in mitral regurgitation over a 6-month period is here on the y-axis. And what you'll notice is that there's a fair amount of difference in the carvedilol group and almost no difference in the control group between before and after therapy. The other interesting to highlight is what they show is that the more severe mitral regurgitation you have to begin with, the more likely you stand to benefit from beta blocker therapy, at least in this group of patients. And we should be being pretty aggressive with our medical therapy as well, not just stopping on starting people on an ACE inhibitor or ARB or a beta blocker, but kind of up titrating and putting them on as many guideline-directed medical therapy options as possible. Now, this was a trial that took patients who were on a stable dose of valsartan and randomized them to continuing valsartan versus the addition of a angiotensin receptor neprilysin inhibitor in Entresto. And what they saw was a modest but statistically significant reduction in the severity of mitral regurgitation. And now that we're focusing a lot on SGLT2 inhibitors, there's actually a trial enrolling patients right now to see the effect on secondary mitral regurgitation. Now, when we take a look at the mechanisms that underline secondary mitral regurgitation, we can kind of infer that a lot of the medications that result in left ventricular remodeling and improved contractility might also have benefit on the severity of the secondary mitral regurgitation itself. But in addition, there's another mechanism here that is sometimes underappreciated, and that's the dysynchrony between the left ventricle, the right ventricle, and in particular the papillary muscles. And as such, there is a role for cardiac resynchronization therapy in patients with secondary MR from left ventricular systolic dysfunction as well. This group in the Netherlands, Van Bommel's group, looked at 100 consecutive patients with at least moderate mitral regurgitation, and they also met criteria for cardiac resynchronization therapy. And they documented what happened over a 6-month period with their mitral regurgitation, and they saw that on average, mitral regurgitation got better, as well as some of the leaflet morphology and the left atrial volumes that kind of help lead to the milieu of secondary mitral regurgitation. They also showed in long-term follow-up, at least up to 5 years, that those who had their mitral regurgitation improve did significantly better than the MR non-improvers. Now, granted, there were a lot of confounding factors here as well, such as who actually responded to CRT from a ventricular standpoint. But when they adjusted for left ventricular ejection fraction, and when they adjusted for cardiac resynchronization therapy effect, mitral regurgitation improvement still had a statistically significant ability to predict outcomes overall in patients with secondary MR in this cohort. And it's not just the long-term benefits that CRT can provide on the ventricle itself. There's actually a fair amount of evidence for acute hemodynamic benefits that cardiac resynchronization therapy can restore. This was an interesting study where they just chronicled a variety of patients seen at their center who had papillary muscle dysynchrony, had at least moderate mitral regurgitation, and the before and after with activation mapping. The patient in group A here in the panel A came to them with a dysynchrony between the posterior medial papillary muscle and the anterior lateral papillary muscle, and they had moderate mitral regurgitation to begin with. Their EKG was notable for a left bundle branch block. And after appropriate cardiac resynchronization therapy, immediately post-operative, their mitral regurgitation reduced from moderate MR without any of the remodeling benefits that the long-term cohort looked at. And similarly, patient B had RV pacing as the form of their dysynchrony, and with the addition of cardiac resynchronization therapy, restored papillary muscle synchrony and reduced the amount of mitral regurgitation as well. And so the combination of this data plus our kind of mainstays in heart failure therapy, I think really speak to the advocacy of using guideline-directed medical therapy in patients with LV systolic dysfunction, and particularly those with secondary MR. And that incurs a morbidity and mortality benefit. But there's also a utility for cardiac resynchronization therapy, which both has effects on the left ventricle, but also on the mitral regurgitation. And that combination can lead to a relative improvement in morbidity and mortality. But what about the mitral valve itself? Are we just mentioning the mitral valve here as a confounding variable and that it's just a surrogate for severe LV dysfunction? Some of the data I presented thus far has kind of painted a picture that's a little bit more in depth than that, and there is more to the story that we're telling. But how about focusing on the mitral valve itself? What happens when we just target invasive mitral regurgitation reduction strategies? Unfortunately, there isn't a lot of surgical literature on what we do with patients with secondary mitral regurgitation. There haven't been many randomized trials in this arena, and the few have been very challenging in small patient panels. But there is some evidence in patients who have ischemic cardiomyopathy who have other indications for surgery, such as coronary bypass grafting. And this was a paper in 2003 that looked at roughly 2,000 patients or so that all had ischemic cardiomyopathy with at least moderate mitral regurgitation. And they tracked what they did over time over a 5-year period of time. And what they noticed was that those who received medical therapy fared worse than those who had revascularization, but that the addition of mitral valve surgery did not incur any benefit over other revascularization strategies. In fact, they were all very similar. Again, this was retrospective analysis, and so there are a lot of confounding variables to report here. A similar study was performed roughly a decade later that took a look at 5,000 patients with ischemic cardiomyopathy and secondary mitral regurgitation. And they had a similar finding to the first paper, in that patients who had medical therapy rather than revascularization did worse in general than patients who were revascularized, but that the addition of mitral valve surgery did not incur a benefit over CABG alone. Now, the authors freely report here that there was significantly more patients who had severe mitral regurgitation than those who underwent mitral valve surgery. So there's a lot of confounding factors that dictate this data. But we do actually have a randomized trial looking at this very specific question, and patients with ischemic cardiomyopathy who have an indication for CABG and at least moderate mitral regurgitation were randomized to CABG alone, which is the blue line, or CABG plus mitral valve repair, the red line. And over a year period, they didn't see any difference with respect to mortality, and they didn't see any difference with respect to cardiovascular events or other cardiac events such as heart attacks or MIs. And so that's as good as we get for randomized controlled data in that arena. But how about isolated mitral valve repair or replacement in secondary mitral regurgitation? There was a paper in 2014 that looked at isolated mitral valve repair and replacement, not in patients with ischemic cardiomyopathy or who are undergoing bypass surgery, but just those who needed mitral valve therapy. And they tried to take a look at the difference between them in roughly 250 patients. Again, the patient cohort was only followed for a year or so, but they did not notice any statistically significant difference with respect to mortality. Unfortunately, this was not controlled with a medical therapy arm. So it's hard to infer what would have happened to these patients had they not gotten mitral valve surgery. They did note that over the course of the 6-month follow-up and 12-month follow-up, on average, there was an improvement in New York Heart Association functional class. But I'd also like to highlight that there was a fair amount of mortality in the 6 and 12-month mark. And I think what this goes to show is one of the main challenges of surgical options with this patient panel, in that overall they tend to be sicker, they tend to have a lower ejection fraction, and they tend to have not as long of a life expectancy as compared with, say, primary mitral valve regurgitation, where there's a robust amount of data to suggest that surgical intervention helps, in particular mitral valve repair. And so there's this natural space here for the option of a less invasive and a transcatheter approach to helping people reduce their severity of their mitral regurgitation. I think we're all familiar here with the Microclip delivery system. And at least in the US, it's the only current FDA-approved transcatheter edge-to-edge repair for mitral valve. Now, across the globe, there are other products that are approved for this indication, and there's currently several other devices, not just clips, that are being studied. We'll talk about those a little bit later. But to familiarize us with the Microclip procedure, it's a clip that's placed on the anterior and posterior mitral valve leaflets. It's usually done via access to the femoral vein and then performing a transeptal puncture to gain access to the left atrium. Using fluoroscopic and transesophageal echocardiographic guidance, the clip is placed. And the goal is to create this double orifice area here and tethering the anterior and posterior leaflets together, usually in the A2P2 scallops, decreasing the amount of mitral regurgitation. This was kind of borrowed from what was called the Alfieri Stitch, studied in the 1980s and 1990s by Dr. Octavio Alfieri. And so this was the surgical approach, and we've kind of mimicked it with a clip. In terms of studying the efficacy of this, the first real trial that looked at, in a randomized fashion at least, the overall safety and efficacy was the Everest II trial. The Everest I trial that preceded this was a safety and feasibility study with just a single prospective arm. And they randomized patients with both primary and secondary mitral regurgitation to either surgical intervention, usually repair or replacement in some patients, to percutaneous repair with the Microclip device. And what they noted was people who had the Microclip required mitral valve surgery down the road significantly more than those who underwent surgery. Now, granted, this was kind of in the early adoption phase of Microclip, and there was a lot of operator experience that has since developed, which what the authors claim is, at least in part, some of the differences here. But they also noticed that there was a significant adverse effect decrease in the patients who got Microclip in comparison to the surgical arm. And this was driven primarily by bleeding, but not only by bleeding events. And I think the subset analysis also paints what they call functional MR here. There was no real difference between surgery and percutaneous repair. And why that's important to us is I had just mentioned before that the overall morbidity and mortality of these patients is high, and they're not all the time a very ideal surgical candidate. And if their 6 to 12 month mortality is somewhere between 15 to 20%, there has to be a lot of push for us to put them through a surgical intervention. And that paved the way to two landmark randomized clinical trials, one being the CoOp trial, which we'll evaluate, and the second being the Mitra FR study. So the Coapp Study randomized roughly 600 patients with moderate to severe secondary mitral regurgitation and LV systolic dysfunction to Microclip therapy or usual therapy with medical therapy. And they saw an overwhelming benefit for those who received Microclip on a 2-year basis. The 3-year follow-up study also showed similar results. There was both a drastic decrease in hospitalizations for heart failure as well as death of any cause. And so when you go to Abbott's website, they're of course latching onto this information. It saves lives, fewer hospitalizations. They might as well put a lifesaver ban up there. And why have 100,000 people chosen Microclip? But the Mitra FR study, which was published in the same New England Journal article, showed a very different result. And they too randomized patients with severe secondary mitral regurgitation and LV systolic dysfunction to medical therapy or device therapy with Microclip. And so, this really gave us a clinical conundrum on our hands here, and in many ways brought about more questions than answers on what to do for our patients. And so the rest of the talk, I want to focus on this difference and why indeed we might be able to explain the differences between the Coapp and Mitra FR studies and how that corresponds to our 2 patients that we talked about earlier. So if you'll remember, our first patient had a moderately dilated left ventricle. His end diastolic volume was 180 milliliters. He had severely reduced systolic function with an EF of 25% and severe mitral regurgitation. I put the values here. After careful consideration and discussion with our surgical and interventional team, our patient ultimately undergoes Microclip, and here are his intraoperative or intraprocedural transesophageal echo images. The picture on the left is a 3D reconstruction of his mitral valve, and we're looking at what's called the surgeon's view, or the view from the atria looking down at the mitral valve. At 12 o'clock here, you can see his aortic valve, and then you see his anterior leaflet and his posterior leaflet. On the right is the same image, it's slightly adjusted, but it's a similar image with color Doppler showing the significance of his mitral regurgitation. He undergoes Microclip and he has 2 clips placed. The image on the left is that same view, kind of from top down from the atria, and you can see the double orifice area that was intended from the Alfieri stitch. The image on the right is a 3D construction from the ventricular view looking up. So we're looking at the bottoms of the microclips here in the middle, and then the orifice that open in to allow blood flow on the opposite sides of the microclip. And he had drastic reduction in his mitral regurgitation. Before image was on the left, and after image intraprocedurally was on the right. And fortunately for him, at his 1-year follow-up examination, this is his transthoracic echocardiogram, he has reduced mitral regurgitation. It's now mild. And he reports, I feel much better. He actually has class 2 heart failure symptoms and hasn't been hospitalized at all. And just kind of a side caveat, he actually had an atrial septal occluder device. You can see it here in FOSS and here along the septal for a persistent bidirectional shunt, but not really necessarily relevant to his mitral regurgitation. Patient 2, on the other hand, had a different outcome. And to recall some of the specifics behind his presentation, he had a severely dilated left ventricle with an end diastolic volume of 210 milliliters. And he had moderate to severe mitral regurgitation with an effective regurgitant orifice area of 0.32 centimeters squared. After careful consideration and discussion with our multidisciplinary team, he too undergoes Microclip procedure. The image on the left is the 3D reconstruction of his mitral valve prior to procedure, and on the right, it's the 3D reconstruction post-procedure. He has a 1-month follow-up exam with a transthoracic echocardiogram, and he too has reduction in his mitral regurgitation. He's graded to having mild to moderate mitral regurgitation, but unfortunately, he's reporting progressive heart failure symptoms. He's actually now on the border of having 3 to 4 class symptoms, and he's hospitalized multiple times, and unfortunately dies prior to his 1-year follow-up appointment. Anecdotal cases from our own institution, but I think there's a lot to be discovered by unpacking what's going on with these patients and putting it into the context of the 2 trials that I previously discussed. So on the left, you see the inclusion criteria and some of the average data for the Coapp study, whereas on the right, I put the Mitra FR study. And what you'll notice for their mitral regurgitation criteria is that the Coapp trial required more severe mitral regurgitation to get in. And that was in comparison to the Mitra FR study. You'll also notice that they excluded those with a very, very severely dilated left ventricle, with here characterized by an end systolic dimension of 7 centimeters. And that resulted in a mean regurgitant orifice area for the mitral valve of 0.4 centimeters squared, as opposed to the Mitra FR, which had less mitral regurgitation. And also the limiting of the left ventricular dilation resulted in the Mitra FR study having significantly more left ventricular end diastolic volume in their mean patient in comparison to the Coapp trial. The other notable difference here is that there was more rigorous criteria for guideline-directed medical therapy and cardiac resynchronization eligibility for the Coapp trial. On average, these patients had more guideline-directed medical therapy and had to be treated with CRT if they otherwise met inclusion criteria. And while that was encouraged in the Mitra FR study, the audits were not as strict. So we're dealing with different patient populations here. To kind of graphically represent it, and we're going to come back to this graph several times over the course of the remainder of the talk, I placed end diastolic volume on the x-axis and mitral regurgitation severity on the y-axis, as defined by effective regurgitant orifice area. The red circle is our Coapp group, and the blue squares are Mitra FR study. Now, this is a big graph, but you'll notice, our patients with severe mitral regurgitation might be in a box like this, and the volumes that our patients have, are spanning 100 milliliters to 250 milliliters plus. And so these are very different patient groups when you take a look at their severity of their MR and their end diastolic volumes. There's 2 possible hypotheses to help explain the outcome differences between these groups. And I'm going to talk about them and some of the evidence, or maybe lack thereof, to describe these models. The first one I'm going to focus on is irreversible left ventricular remodeling, which, it's not a good cardiology talk, I've been told, unless there's at least one pressure volume loop, so I had to throw this there. But in patients with mitral regurgitation that have secondary MR over time, there's a negative feedback loop that ultimately spirals to having patients have more and more decompensated mitral regurgitation. you can see that their end diastolic volumes continue to change over time from compensated MR to translational MR, ultimately to decompensated MR, and they have increased peak wall stress as that change happens. You'll also notice that while the stroke volume is relatively similar in the groups with mitral regurgitation, the relative ejection fraction, which is the stroke volume over the LV end diastolic volume, is reduced. And so that's what we see in our patient population, that over time, their ejection fraction might reduce because of the mechanisms of MR. And this effect was actually studied to some degree in the 70s, believe it or not. It's kind of funny how things that were studied a long time ago, 40 years ago, are now kind of being revamped with the advent of new interventions. And while this was a small trial performed in patients who had secondary MR who underwent surgical intervention, the points here that they make have some validity to them, in that what they noticed is that in the cohort of patients that had very severely dilated ventricles, as noted by an end diastolic dimension of around 8 centimeters or so, that there wasn't really a benefit to ventricular dilation over the course of their follow-ups in 1 month and 2 month and 3 month intervals. Whereas when you take a look at those with mild to moderately dilated left ventricles, on average, there was a reduction in their left ventricular end diastolic volume noted by their end diastolic dimension. And a similar theory is thought to hold true with respect to atrial secondary mitral regurgitation. Sometimes people will refer to this as atrial functional mitral regurgitation, or the effect of having a very, very large atrium in the setting of atrial fib on annular dilation causing secondary mitral regurgitation. And this was an interesting study where they took people with at least moderate mitral regurgitation, with a third of them had roughly a third of them had severe mitral regurgitation. And they tried to turn everybody into sinus rhythm, either by catheter ablation or with cardioversion. And then they looked retrospectively at those who were able to maintain sinus rhythm or those who had recurrence of their atrial fibrillation. And what they noticed is if you were able to maintain sinus rhythm, you had significantly reduced mitral regurgitation. Here's the sinus rhythm arm in follow-up. Here's the sinus rhythm arm at baseline. And there was no difference to begin with between the arm that had recurrent atrial fibrillation and those who underwent sinus rhythm in terms of severity of their mitral regurgitation. But if you had recurrent atrial fibrillation, if we were unable to get you in sinus rhythm, you had on average more severe mitral regurgitation. And one of at least the hypothesized mechanisms behind this is it's really hard to put people in sinus rhythm when they have these giant left atriums and have excessive annular dilation and the negative spiral feedback loop that we talked about of secondary mitral regurgitation. We've all been tasked with cardioverting these people, and our EP colleagues has had to try to take them to the EP lab and do catheter ablations. And in general, there's a theory out there that's thought to say at some point the atria are too large, this patient's been in AFib for too long, and AFib begets more AFib, that it's probably less likely that we're able to reverse them out of the stages of atrial dilation. When we extrapolate this data to our model, and this is a hypothetical left ventricular remodeling model, but similarly discussing the patients with secondary MR, there could be an example here made for as the ventricle gets more and more and more dilated, maybe we're unable to recover some of the remodeling benefits that mitral valve intervention has. And so again, this is a hypothetical model showing that in the area in green, patients might be eligible for LV remodeling, but as you get more and more dilated, there might not be that opportunity remaining. A lot of work has to be done in this space. And again, I'll posit that this is just a model rather than true evidence behind this. The other hypothesis that I'm going to discuss today, and there's been a lot of traction on this recently, is the concept of disproportionate mitral regurgitation. And so I'm going to take a moment to explain this slide too, because we've added a couple features to our end diastolic volume and mitral regurgitation severity. The group here in green has a disproportionate amount of mitral regurgitation in comparison to the left ventricular volume. There's a lot of MR despite the difference in volumetric changes. The group here in gray has a disproportionate amount of left ventricular dilation. Their LV is very, very dilated with less MR in comparison. And then there's a group in the middle that probably has a proportional amount of mitral regurgitation in comparison to the left ventricular dilation. These cutoffs are a little bit arbitrary, but were actually studied in some retrospective reviews going forward that we'll discuss. But maybe that we've divided the group of CoAP patients and Mitra FR patients into this disproportionate mitral regurgitation model and our proportionate mitral regurgitation model. This was best looked at least thus far, by the European group who did a registry analysis at multiple different countries and looked at roughly 1,000 patients who had Microclip. They divided 3 groups of patients into MR dominant group, or the group here, which we've called disproportionate amount of mitral regurgitation, and their cutoffs are seen above. And they looked at the LV dominant group that had disproportionate amounts of LV dilation, and here's the cutoff. And then the group in the middle, the MR LV codominant, as they've described. And I put this graph here as kind of a reference point in comparison to our Mitra FR patients and our CoAP trial patients. Not surprisingly, they saw a statistically significant difference with left ventricular and diastolic volume. That was kind of by design. Effective regurgitant orifice area, again, that was kind of by design. And ejection fraction, and maybe skewed more towards the patients with severely dilated left ventricles, that their ejection fraction is lower. Again, a little bit by design. Importantly, though, they were able to show that regardless of which group you fit in, Microclip was successful in reducing mitral regurgitation, and very similarly so. So there's a lot to kind of unpack about this slide, so I'll help describe it. The 3 columns here on the left are baseline mitral regurgitation severity as color-coded, as mitral regurgitation severity at discharge and at follow-up in the MR dominant group, the group here that had disproportionate amounts of mitral regurgitation. A similar graphic was displayed for those in the middle group, the proportional amount of mitral regurgitation, and a similar graphic was displayed here in the LV dominant group, those who had significantly more left ventricular and diastolic dimensions. And what they show is that there is a drastic reduction in mitral regurgitation severity across each group, but overall, whether you're in the disproportionate MR group or the left ventricular dilation group, you had a pretty similar reduction in severity of MR, which is an important confounding factor in the data that I'm going to present here. Then they looked at the mortality of these patients, who had worse outcomes overall. And it's hard to say that there wasn't a true comparison here because it was a registry analysis. But in these 3 groups, what they noticed is if you were in the left ventricular dominant group, as composed to the groups here with proportionate and disproportionate mitral regurgitation, they didn't necessarily see a difference between those 2 groups, as we would expect to see if that proportional model would hold true all the way across. So on one hand, there's some evidence to say that this model carries weight, that those with severely dilated left ventricles far worse than those with proportional or disproportionate amount of MR. And on the other hand, there's a little bit of contradictory information here in that we weren't able to see a true difference from the addition of Microclip in between these 2 groups, where the Coapp trial and the Mitra FR study were different. Now, again, to mention that these cutoffs were relatively chosen for the purposes of making that difference between the Coapp and Mitra FR study, and no true regression analysis was performed to kind of see if the ratio of EROA to left ventricular and diastolic volume was predictive of outcomes. Grayburn happened to really extrapolate this data further, and he added data from the Coapp trial as well as the Mitra FR study. And again, there's a lot of information to unpack on this graph, so I'll hopefully help explain it. On the x-axis is the ratio of the severity of mitral regurgitation to the end diastolic volume ratio, that EROA to LVEDV we've been talking about. And on the y-axis is mortality over the course of 2 years. The patients in green were treated with medical therapy, and the patients in red were treated with devices. The circles represent patients in the Coapp group, with the large circle here in the middle being the overall cohort of patients, and then the smaller circles being subsets of the Coapp group. The triangles represent patients in that Euro registry that we just discussed in the slide before, and the squares here represent the patients in the Mitra FR study. And when you graph this over time, taking a look at those with disproportionate mitral regurgitation and those with proportional mitral regurgitation, you do notice a trend towards an improvement here with Microclip therapy as composed to medical therapy. Opponents to this review note that a lot of the data here is skewed by the Coapp trial and that there's no true marker for a control group for the Euro SMR registry to be had. But nonetheless, I do think that there's some important takeaways. The other thing that they'll note is there still may be some benefit derived from folks with less proportional mitral regurgitation, although that benefit might not be as pronounced as those here in the very disproportionate mitral regurgitation group. And that kind of leads us to the next steps. I think there's a lot of space for work in this arena. And I'm very pleased to say that the University of Washington has collaborated with a variety of different institutions to come up with the Microclip for Functional Mitral Regurgitation Registry, where we're compiling all of our data over the last 5 or 6 years for patients who underwent Microclip here at our institution with secondary mitral regurgitation. We've excluded those who are on mechanical circulatory support, but have included patients otherwise that would have been enrolled in the Mitra FR and the Coapp study. And we're combining our data with some of these other very prestigious institutions to hopefully help define that specific question on if there's any weight to the two hypothesized models behind the difference in functional outcomes in the secondary mitral regurgitation groups. And with that, I'd like to kind of highlight the takeaway points that I'm hoping people have concluded. One is that secondary mitral regurgitation is very important here. It's not just that it's there, but it incurs a worse prognosis. And we should be really thinking about these patients with a multidisciplinary approach to their heart failure management and guiding individualized care, not just putting on some algorithm of treatment. Every patient that can be possibly put on guideline-directed medical therapy should have aggressive guideline-directed medical therapy. We should thinking about restoring sinus rhythm for these folks, particularly before they've reached that stage of excessive left atrial dilation and mitral annular dilation. We should be really promoting the concept of papillary muscle resynchronization therapy for those who have other indications for cardiac resynchronization. And we should be considering revascularization in our patients with ischemic cardiomyopathy who have unrevascularized territory. Additionally, as there are more and more devices that come out, there will be a more specific role for individualizing care. These are 3 devices that are currently being studied here in the US as well as in Europe. The one on the top left is the Cardioband device, which is effectively a direct annuloplasty ring that's placed in a transcatheter-based fashion. And the point is to reduce, obviously, mitral annular dilation. The Carillon indirect annuloplasty ring is a device that fits inside the coronary sinus. And while it also decreases mitral annular dilation, also has an effect to kind of cinch the atrial enlargement, particularly in those with atrial secondary mitral regurgitation. The Ancora AccuCinch device is effectively a left ventricular sleeve. It functions to try to decrease the left ventricular volume in those with a severely dilated left ventricle. And so the more and more we see these patients, the more we're going to have to think of secondary mitral regurgitation as a heterogeneous group. And as imagers, it'll be very important for us to note what we think the secondary MR is from, not just stating that there is secondary mitral regurgitation. And lastly, that there is a role for transcatheter edge-to-edge repair. We're not 100% certain on who the subset of patients is, but we know that in terms of thinking about people, there's at least 2 hypothesized models, and we're going to aim to answer these questions more and more over time. The first being reversible LV remodeling, that we should try to target these patients maybe before their left ventricles are severely dilated. And the second group is that the disproportionate mitral regurgitation model might be the patients who stand to gain more benefit, although there still might be some benefit gained from those with proportionate amounts of mitral regurgitation. And with that, I have a lot of thanks to report to many of my mentors and colleagues and people who've helped me along the way. There's too many people for me to thank to list all the names. And also other site directors at University of Michigan and University of Colorado, as well as the MFIRE registries. My cardiology co-fellows who've been there kind of going through the process with me this whole last several years, and my family who have had to put up with several call nights, me waking up in the early morning, coming in and extending training and not being there for dinners and other things. So thank you very much for your attention. I'd love to answer any questions